So it's the top of the hour. Good evening, everybody, and welcome to this CPC. It's good to see a lot of pathologists, I think, and some clinicians as well. This is going to be a very interesting case, and it is my honor to welcome Professor Narayan Prasad. Thank you so much for accepting the invitation. He is head of Department of Nephrology at SGPGI, Lucknow. And I have seen this. He's deeply committed to enhancing kidney care in India. He has leadership positions in the Indian Society of Nephrology as well as in the International Society of Nephrology. And can we, with a round of applause, welcome him to the dais to present it.
First of all, I would like to thank Dr. Bhaumik for this opportunity to be here in the great institution, the pride of the nation, All India Institute of Medical Science, Delhi. So really, I have been here for one CPC about 6-7 years before for the pediatric nephrology, and so that was again a great time. So in that time also, I have enjoyed doing this CPC. So presently, I can say you the heading is just a case of persistent nephrotic syndrome, looking like very simple. But CPC is never simple, it is complex. And I say it is a treasure hunt. Something is hidden by pathologist, our colleague, and you have to hunt for finding out the treasure. So that kind of things is really a CPC. So just a 43-year-old man presented to a local hospital with a persistent oral ulcer. He had a whitish lesion on the left buccal mucosa. He has a history of the substance abuse, like you can say tobacco chewing for 20 years, BDA smoking 20 per day for 20 years, alcohol 10 grams of the country liquor for 20 years. So you can think of about this gentleman. I can say you gentleman, but that none of the behavior was of the gentleman you can think of. So biopsy finding of this oral ulcer was, from one side it was leukocytoclastic vasculitis, other side it was expected finding that leukoplakia with a dysplasia. So management at that time was the very conservative management, but additional finding that was detected during that period of the time was the hepatitis C infection. SCB was reactive, but SCB RNA was negative, and treatment record was not favorable. Patient did not follow up. Gastroenterology evaluation assessed for the chronic hepatitis C, SCB RNA negative. Fibroscan was suggestive of cirrhosis. Upper GI endoscopy, there were no varices. And the impression from gastroenterologist side was the compensated cirrhosis attributed to obviously alcohol and chronic hepatitis C. No urinary symptoms, no other systemic manifestations, no history suggestive of connective tissue disease. So nephrology referral. Patient had bilateral pedal edema and proteinuria. So on investigations here, what you can see, there was severe hypoalbuminemia. One positive finding was the low C4, very low C4. Anti-SCV was reactive, but SCV RNA was negative. So when you are analyzing, this is very common in nephrology practice that anti-SCV is positive, SCV RNA is negative, particularly when our patients on dialysis comes. Most commonly, reason could be the resolved infections, post-treatment course, false positive anti-SCV, and sometimes low level or intermittent viremia can happen. So at that point of the time, you might not have SCV RNA, or sometimes technical or pre-analytical issue can be there. So investigations done at AIIMS nephrology department or other sets of investigations. So electrophoresis was showing phantom bind 0.2 gram per deciliter. Immunofixation, serum immunofixation was showing IgM kappa. And SFLC, when you look at the kappa lambda ratio, it was 1.68. For normal renal function, upper limit is 1.65. So, but at this point of the time, his serum creatine was 1.6 probably. One report only was showing some creatine of 1.6. Other reports were normal of the serum creatine value. So when looking at the GFR, it was falling between 45 to 59. Cutoff should be 0.46 to 2.62. Little higher because of less excretion with this low GFR of kappa or lambda can happen. So, but most of the times his renal function creatine value was normal. So we think of probably the patient has kappa monoclonal gammopathy would be ongoing. So summary, when looking at the summary, nephrotic proteinuria, hypoalbuminemia, increased cholesterol, low C4, severe reactive, underlying cirrhosis, compensated chronic liver disease, you can say, hepatitis C associated, alcohol associated. Patient was advised for kidney biopsy for leak of the albumin in the urine. Patient did not consent and was lost to follow-up. So whenever we see hepatitis C infections with proteinuria, few differential diagnosis comes in the mind was MPGN, membranoproliferative glomerulonephritis, type 1 pattern. That was the classical. Then you think of the cryoglobulic glomerulonephritis because C4 was persistently low. And less commonly, membranous and FSGS. So urine examination is very important for all of us as a nephrologist. When you look at, this is the reflection of the kidney functions, what is going on in the kidney. You can see throughout, very active urine sediment, proteinuria of the 3+, RBCO went up to the tune of 90 to 100 for high power field. So it was looking like the proliferative glomerulonephritis. So we can rule out some of the non-proliferative glomerulonephritis like minimal change disease, FSGS and MGN. It was looking like less likely. So probably proliferative glomerulonephritis. Again, further investigation, next set in November, December of 2025. Patient again reported to nephrology OPD with a persistent nephrotic syndrome, proteinuria of 3+, RBC of 18 to 20, and low C4. Here we can see low C4. Hemoglobin, TLC, platelet, everything was normal. So clinical course, this time the patient consented for kidney biopsy. Kidney biopsy report was immune complex mediated membranoproliferative glomerulonephritis. Most of the times you are blind, without IF, without electron microscopy. So this is so-called the treasure and hunt practice. Something has been hidden. But based on that practice, patient has been started on oral prednisolone 30 milligram per day, and on follow-up, there was no significant response after 6 weeks, so dose has been increased to 50 milligram per day. So whenever we see MPGN in our practice, we show this is not a diagnosis, it is one of the pattern. So you might have the multiple differential diagnosis. One of the important category is immune complex mediated MPGN, where we can see where we want to put our weight is to infection, where hepatitis C was there, cryoglobulin because C4 was very low, C3 was normal in this person, and you can think of autoimmune, we can rule out IgA nephropathy, MPGN variant can sometimes you can see when there is late presentation, monoclonal gammopathy, PG and MID, but C4 was normal usually in this condition, and C3 should be usually towards the lower side, but there was monoclonal. Whenever we see even fan trace of the M band, we should not neglect it. That is the message. Even the fan trace we should go for and investigate this patient deeply. So other MPGN pattern could be complement-mediated MPGN, thrombotic macroangiopathy, chronic endothelial injury in transplant settings, and some other causes like LCAT deficiency leading to some of the kidney condition or glomerular disease. But there is no activation of alternative pathway. C3 was almost throughout normal, only C4 was less. So probably we are ruling out. So MPGN pattern, very simple. If immunoglobulin and C3, immune complex pathway, you can have three important things: monoclonal immunoglobulins, cryoglobulins, and polyclonal immunoglobulins. Monoclonal, PG and MID, cryoglobulins, cryoglobulic glomerular nephritis or MPGN can be there, and polyclonal IG, infection and autoimmune infections could be the possible hepatitis C infection was there. Sometimes when you see any immunoglobulins is there, then the current practice is there, you should think of analyzing the IgG subtypes. So if you have IgG3, you can think of PG and MIDD. If you have more of the IgG1 along with the IgG3, you can think of cryoglobulic IgN, and usually predominantly IgG1 MIDD could be the possibility. So readmission again happened in February 2026. Here you can see general examination was nothing contributory, BP was normal, there was a poor oral hygiene that was expected, childhood abdominal surgery was there for intestinal obstruction that we do not know. Is there any clue or whether, I don't think it was related. So readmission in February 2026, what we have seen, again C4 was low, urine was very active, reactive, RBC was 90 to 100. SCB RNA this time turned out to be positive. So, and rheumatoid factor was positive. Again, second time, serum electrophoresis showing front end band, and SFLC ratio kappa by lambda was 1.72. Upper limit is 1.65. So there is some degree of cholinergic you can think of. So analysis, can I take water? So analysis of the complement is again important. Many of the students' mind it came that why C4 is so low sometimes, and this is very classical teaching from our MBBS days or MD days. Only low C4, what you think of the one disease, that was the cryoglobulinemia. So that is very classical teaching. And why it becomes low? You can see activation of the complement classical pathway. C4 comes before C3, and so a lot of consumption of the C4 happens, and you can have the alone C4 low, and subsequently you might have the low C3. But alone low C4 can, in that way, we can see this patient has the persistently low C4 throughout the course. So then look at this whole investigation here. We can see in the last, the patient become SCB RNA positive. Everything we have explained you. So possible differential from our point of view, SCB related cryoglobulic MPGN or PG and MIDD was my weight on these two differential diagnoses. But few important things. In SCB related cryoglobulic MPGN, uncommon finding, evidence of paraproteinemia, IgM kappa. And in PG and MID, unexplained or uncommon finding was rheumatoid factor positivity, can be seen, but it is rare. Low C4 level can be seen, reported in the literature, but it usually are rare finding. So clinico-pathological correlation between SCB and MPGN pattern, when we look at, in literature, the strongest known association in medicine is between SCB and cryoglobulins. That is the common practice. Whenever you read from pathology days, you will find about 80 to 90% of the mixed cryoglobulinemia is linked to SCB. So you should have cryoglobulin levels, but again, this has been hidden. So we have to find out. So one of the very important literature in 1993 published in NEJM, what we can see here, only 8 cases reports published in NEJM. You can think of the value of this paper. Here, 62% of the patient has cryoglobulinemia. This was the SCB infection and membranoproliferative pattern, where we can see has a 62% has the cryoglobulins. And when the cryoprecipitate has been analyzed, 50% patient has the SCB RNA in their cryoprecipitate. So that can be there. Similarly, when looking at the complement level, low C4 was reported in 7 out of 8 cases, and low, but here you can see low C3 was also. It is probably the advanced stage of the disease. They have taken into the literature. So whenever we think of the monoclonality, we almost try to see whether there is any hidden malignancy. So PET-CT was done. That was not showing any metabolically active lesions. Cyclic identification of the IgM kappa 2 times done. Serum free light chain ratio was 1.7, suggestive of some monoclonal B-cell clone. So type of cryoglobulins, here we can see type 1 and 2 and 3. Type 2, monoclonal IgM plus polyclonal IgG. Hepatitis C associated, low C4. We think of low C4, think cryoglobulinemia, MPGen pattern, phantom band, strongly suspect type 2 cryoglobulinemia or MGR. So cryoglobulinic vasculitis, whenever we have IgG, SCB complex, along with this looking like at the rheumatoid factors, then it becomes like the cryoglobulins that gets deposited into the vessels and can manifest as a vasculitis, a smaller vessels vasculitis. And target organ involved are usually a skin. This patient has leukocytoclastic vasculitis that we should keep in the mind in the first report. No other, I have not examined, so I do not know whether there was any other vasculitic crisis or not. So can SCB lead to increased formation of monoclonal kappa? Yes. Sometimes this chronic persistent SCB infection, polyclonal, may go for the oligoclonal selections, and then finally you may have the monoclonal selections. They can have the B-cell clonal expansion, lymphoma. B-cell non-Hodgkin's lymphoma is known to be associated with hepatitis C infection, and mixed cryoglobulinemia can be there. So SCB may take monoclonal pathway with the persistent B-cell stimulation and the emergence of the B-cell clone or plasma cell population, production of the increased monoclonal immunoglobulins, and deposition of any immunoglobulins in glomeruli can lead to proliferative glomerulonephritis, minimal monoclonal immune deposition, PG and MID. And you can say this falls under MGRS. What is this MGUS? Because we know that myeloma protein, M protein was less than 2 grams. That was not fulfilling the criteria of myeloma. When it is without organ damage, it is called MGUS. But it was causing some kidney injury, so you can think of it was MGRS. So then further course go on, electron microscopy, where how kind of the deposit of the fibrils are there. This is fibrillar, macrotubulars inclusion, or crystalline deposits. And a non-organized deposit here again comes as the MIDD or PG and MIDD, the differential diagnosis. So C3G I have already ruled out. So this is the Dr. Sethi's classification. When we look at the different syndromic presentation of monoclonal immunoglobulin deposition related renal disease, acute renal failure, nephrotic syndrome, nephrotic nephritic syndrome, and proteinuria or progressive disease. This patient has a nephrotic nephritic presentation, very active urine sediment. So in that, PG and MID and cryoglobulinic GN would be the possibility, what I think of, the nephrotic syndrome. When we look at this monoclonal antibody comes from the 2 clones. Might be from the B-cell clone or might be from the plasma cell clone. Here you have the malignancy which we have ruled out. But in both categories, you might have the non-malignant percent. MGRS in both clones, in B cells and plasma cells. So MGRS would be the one of the possibility here based on this flow chart, where we put weight. I think this monoclonal deposition can happen in other parts of the kidney and tubules also, but in glomerular depositions here we can think of 3 important differential diagnoses: MIDD, PG and MIDD, and cryoglobulinemia. Patient has heavy proteinuria, so you cannot think of the other depositions. Predominant depositions here was in the glomerulus. So Other important things are coming up, the MIDD versus PG and MIDD. If you could have the electron microscope picture, you can just click it. When on the light microscopy, when you have nodular lesion, like the diabetic nodular sclerosis, you can think of probably you are dealing with the MIDD in these conditions. Otherwise, if MPGN pattern is there, you can think of you are dealing with the PG and MIDD. So electron microscopy becomes very important, and determining the clonality from where this monoclonal antibody is coming, that is also important, particularly from the management point of view. Light microscopic nodular MIDD, proliferative PG and MIDD, rule of thumbs, linear depositions on electron microscopy, MIDD, and granular PG and MIDD, EM clue. If powdery along the glomerular basement membrane, tubular basement membrane, both MIDD. If granular deposits, PG and MIDD. So PG and MIDD was, but one thing is there always, for making the diagnosis of the PG and MIDD, you must rule out the cryoglobulins deposits. So that is usually the criteria usually given. So here the situation where both can coexist, or it was the two different entity in this group of the patients. So usually for the monoclonal clarity, we go on doing these investigations. But when you have the IF study, like here, this is simulation, not the real case. So kappa or IgG3, you can think of, probably we are dealing with the PG and MIDD. That makes your life simple. Then different kind of the electron microscopy deposits can give you some hint. Then you go on doing this clonality, whether this is the plasma cell origin or B cell origins immunoglobulins. But it can cause injury, depositions in kidney, skin, liver, heart, and bone marrow. When we look at the MPGN kind of the pattern is there, mimicker of the PG and MIDD with monoclonality. Then whether this is the malignancy or non-malignancy, if you are ruling out malignancy, MGRS related PG and MIDD, when you have the infections here, in this case was the SCV, you can again think of infection associated PG and MIDD, and some remains still unclassified. So looking at this paper, Nasser was in 2004 was the first to give this description of PG and MIDD. In that case, only first report, 20%, 2 cases out of 10 had low C4. But in 2020, here 17 case reports did not show any low C4. So C4 low was actually throughout the course of the patients, it was very low. So it is looking like unlikely that PG and MIDD would be there. So we have 3 PG and MIDD, cryoglobulin, SCB related MPGN, low C4, plus minus C3, most of the time positive, MPGN pattern, immune complex was detected during the first diagnosis. So SCB related MPGN. Cryoglobulins report was not given, but low C4 indicates that there will be cryoglobulins. Some of the factors like monoclonality is there. It is quite possible PG and MIDD features also might be there. So can PG and MIDD, cryoglobulins and MPGN coexist together? So that is the real question. Yes, PG and MIDD and cryoglobulin are not mutually exclusive. Both can arise from the same clone B cell process and may exist in a single patient. And we have some case reports like persistence of the SCB stimulates some of the, as I have told you, it may take the monoclonal selections, oligoclonal and monoclonal selections, they can produce some of the kappa chains and can get deposited into the glomerulus, can lead to the similar kind of the features. So MPGN pattern, cryoglobulinia, monoclonal proteins, go back to the NEGM 8 case reports. It is looking like cryoglobulins would be there. So our final diagnosis, nephrotic syndrome, SCB associated immune complex MPGN with a type 2 cryoglobulinemia, MGRS, MGN, MIDD might be overlapping some features of both, or it is quite possible in isolation also. So thank you, ladies and gentlemen. Thank you for your kind attention.
Thank you for that extensive discussion. I'd like to invite any questions from the audience. Any thoughts on the differential diagnosis? Do you think there are two things, one thing, something else? Nobody's bothered about the buccal dysplasia, I think. Anybody is thinking about that? No. I'd like to invite Dr. Bhaumik from the treating unit to give his thoughts till now.
Thank you, Narayan. I think you've done a very good job as a clinician from the material given. I'll just make one or two points. One is that because a lot of students here, I'd like to clarify one thing that throughout the protocol, clinical protocol which we have written, I've written persistent nephrotic syndrome. I didn't write resistant because by our adult definition, it is 16 weeks. Patient never received 16 weeks, so that's why I just use the word persistent. But of course, the implication is that we were trying to find out the cause of the nephrotic syndrome. The issue was that HCV, now that the initial one report of HCV antibody positive, the RNA report was negative, and we didn't have any real evidence of any treatment given. So we were not even very sure whether, how much HCV was playing a role in this case or not. The differential was, as he has described, that we did think that since C4 was so low, it would be cryoglobulin. Unfortunately, the first cryoglobulin report was also negative. Okay, let's see subsequently. So the cryoglobulin report is also negative, but we did make the differential of, and that is the reason why we were not happy with the first kidney biopsy report, which was immune complex. Nothing much was hidden apart. It was immune mediated, and that's the reason why we went ahead with the second kidney biopsy to understand if we could really learn something more. And apart from that, we did some more tests. Thank you.
Malignancy was really pictured. Any pre-malignant conditions, whenever you have, the PET CT has been done, you can think of a little bit whether, again, a stimulating factor for the B cell, plasma cells, and causing the secretion of the excessive immunoglobulins. That kind of things always came in my mind also. So that was the one pre-malignant conditions, leukoplakia was there, and that was showing some dysplasia. So that was definitely there. The PET CT was not showing any active malignancy. So that was the one thing. Other thing, probably 2 times SCV was basically a reactive just, and SCV RNA was negative. And giving the steroids probably might be the latent, and so that flare up and becomes SCV RNA positives. That got to this activation of this disease.
While I'm opening my PPT, any thoughts on from gastro when the liver disease workup was done? At that point, also no antiviral therapy was initiated for the same reason that HCV RNA was not detectable, even though the patient was determined to be cirrhotic. So just to make that point. Okay, so let's move on now to the pathology. So for us, the story started with the first kidney biopsy. This came in November 2025. This is the pertinent clinical information with which we saw the biopsy, that we have an adult onset nephrotic syndrome. There is cirrhosis, though HCV RNA is negative with an anti-HCV antibody reactive. And there is a faint M band, which is of course very worrisome to us. Every time we look at the kidney biopsy, it is small and it contains M kappa. With this was the biopsy that we received, and you can see that we have both cortex and medulla, small focus of subcapsular scarring with 2 globally sclerosed glomeruli, but we had a good number of open glomeruli to look at with a total of 19. As we take a closer look, we could see that there was chronic damage. So you can see that there is tubular atrophy, interstitial fibrosis with non-specific infiltrates. So we're looking at a progressive kidney disease and absolutely proliferative. So this proliferative glomerulonephritis had evidence of mesangial hypercellularity. You can see a lot of endocapillary hypercellularity and even some neutrophil infiltration. So we were looking at a proliferative GN. On PAS, you see that the mesangial expansion is PAS positive. Mason's trichrome shows us that there is the beginning of a little bit of collagenization. But it's the silver methenamine demonstrating the segmental GBM reduplications, as you can see here, which tells us that this pattern of injury is membranoproliferative GN. One cellular crescent was seen. In terms of vasculature, not too bad. We're seeing an artery with some mild intimal expansion and some hyaline arteriolosclerosis. So no intimal arteritis or vasculitis. So we had an LM diagnosis of MPGN, and as Dr. Narayan showed us, this would be our approach. Is it complement mediated? Is it immune complex mediated? Of course, we've already told you it was immune complex mediated, and now we know that in those situations, we're looking for three things. Is there any underlying infection? Is there any autoimmune or rheumatological disease? Or is there any underlying monoclonal gammopathy? So when we looked at this MPGN, these were the thought processes, like what we were thinking based on the clinical information. We know the patient has a CLD. A CLD can drive an IgA nephropathy secondary, and it can commonly show an MPGN pattern. So that was one differential. Query HCV, some vague history of, yes, there is HCV around. Could this be driving an IC MPGN in terms of infective etiology? Could it be driving a cryo, which is then hitting the kidney, forming an MPGN? Or are we dealing with an MGRS? Do we have an MPGN with monoclonal deposits? So what we needed, of course, is immunofluorescence. So this is now the fill in the blanks that we are providing. So let's look at the IgA first. The IgA was traces to 1+. Doesn't look very significant. We have a non-dominant IgA. We ran a GAL deficient stain. You can see the positive internal control. The IgA is not mucosally derived. We don't think this IgA is getting pushed into the glomeruli as a result of the CLD. So that has been excluded. So the IgA is coming with the rest of the GN. What is the rest of the GN? This was containing IgG 2 to 3+, and strong IgM as well, 3+. To me, this did not look like entrapment. It looked like there was good coarse granular staining associated with significant C1q deposition, which explains the low C4. We have evidence of classical pathway activation. We did not see any C3 there. And there seems to be a difference between the kappa and the lambda. So the kappa was 2 to 3+, but lambda is not absent. Lambda was up to 1+. So if I put in a summary of the immunofluorescence, the first thing that troubles us is the kappa lambda. And we start thinking, well, are we dealing with an MGRS? And as Dr. Narayan had mentioned, is this a PGN-MID? There were no extraglomerular deposits, so we were not thinking at all in terms of other MGRS like an MIDD. So we're looking at glomerular restricted issue, which within the MGRS would come into a PGN-MID. And we have the M and we have the kappa, which if you remember was the M band. It was the M kappa. The problem, of course, is we have too much G. So what is this G? For this, we needed to do subclass staining. So when we did subclass staining, we saw that it's not a single type or subclass. We have G3 along with G1 and a little bit of G2. This is a polytypic IgG. What about the kappa lambda? We did recheck. We performed enzyme digestion on paraffin block just to confirm that, yes, there is a significant difference. It's the same glomerulus, and you can see that the kappa is significantly more than the lambda. So we move on to EM. Just as we saw the deposits on IF, on electron microscopy, we identified deposits. These were predominantly in a subendothelial location. Let me tell you, there were few. It was not full of deposits, unlike the immunofluorescence. And we do sometimes see that. So it was subendothelial deposits. They were immune type, non-organized, and they were showing significant resorption. And you can see the capillary wall remodeling resulting in the MPGN pattern. Interestingly, a lot of subepithelial deposits. You can see subepithelial location deposits here and this one here, pushing into transmembranous, again partly resorbed. A lot of remodeling in the capillary walls. Again, you see the deposits. They are not fibrillar. They are not microtubular. They are maybe a little clumped. So what do we have? We have an MPGN. It is immune complex mediated. The immune complex mediated MPGN is being driven with an M, a polytypic IgG, but kappa more than lambda. And EM shows us unorganized immune type subendothelial and subepithelial electron dense deposits. So when we look at this, we're again coming back. What do we think is driving this IC-MPGN? We can only rule one thing out. We know it's not an IgA nephropathy related to a CLD. That is excluded. Could this be a cryo? I don't know. I'm not seeing any cryo plugs, which is classical for cryo-GN. I'm not seeing any organization of deposits. At the time of this biopsy, we don't have any active HCV. Could this be monoclonal? Well, there is kappa more than lambda. So we needed more information, and I will be calling upon my colleague, Dr. Jasmita, as we dive deeper into the case.
So good afternoon. We got roped in when the cryoglobulin testing came to us. And this was the sample. You can see that the serum shows a deposit right here. It appeared on day 1 itself a little bit and then stayed till day 3. Now, typically when we see a deposit, we would like to heat it to 37 degrees centigrade to see if it resolves or doesn't resolve. To our surprise, it did not resolve at 37 degrees centigrade. So now at this time, we would assume that maybe the deposit is something else and it's not really cryoglobulin that we deal with. Simultaneously, we also process plasma to see if there is cryofibrinogen or not. So in this case, there was both cryofibrinogen as well as cryoglobulin. Incidentally, it pays to have colleagues who do the reading with you. So therein, my colleague comes in. She tells me that I saw a report that the deposit may resolve at 56 degrees centigrade. So we heated the sample to 56 degrees centigrade and it actually did resolve. So this was a heat insoluble cryoglobulin, very likely. And at this time, we actually asked Ritu ma'am to help us to run the immunofixation on the dissolved cryoglobulin. And the dissolved cryoprecipitate, it actually turned out to be again IgM kappa with polyclonal IgG. So that was the same pattern that was there on the serum immunofixation as well. So this was the literature for heat insoluble cryoglobulin. Very, very few cases reported so far. Incidentally, for this heat insoluble one, in the second paper, they were the ones who actually first attempted heating to 56 degrees centigrade. Otherwise, it is not a typical procedure. In fact, this was interesting that usually if you would not, if the cryoprecipitate doesn't dissolve at 37 degrees centigrade, many centers would actually end up reporting this as negative. And this was one of the papers which discussed this and confirmed that they could resolve it after heating at 56 degrees centigrade. And theoretically, they will cause more severe disease as well. So Dr. Geetika really wanted to do the electron microscopy for the cryoprecipitate as well. And here also it was more fibrillar than just granular and rather than organized like you saw in the kidney biopsy. Now, what about the HCV testing? Typically, we've heard that HCV RNA was negative to begin with. Maybe the steroids activated it, but here could the cryoglobulin have played a role? So we look back at the reports, and incidentally, in the month of June, once from our department earlier as well, we had given this out as cryoglobulin positive, but a subsequent report gave it out as negative. And this brings us to the intricacies of cryoglobulin testing. The sample draw, the transport, everything is important. So we need to collect samples with pre-warmed syringes, patients in the lab rather than shipping samples to the lab. Because if the samples are shipped and the cryoprecipitate happens right there while the shipping part, then we will not detect it in the sample. Incidentally, rheumatoid factor continued to be positive. As was highlighted earlier, C4 was persistently low throughout the course of the disease. And there was a decline in the C3 levels by the time we saw the patient back in the month of January and February. HCV RNA, you can see, tested twice here. Both times it was negative. And the M band had not really increased a lot in the amount during the course of the disease. So as Sir said, there could be window period, there could be transient viremia as a cause, or it may be a false positive anti-HCV antibody. So this, if we are suspecting HCV strongly, the results should be retested, which in this case was already done twice and it was found to be negative. So we thought, let us see what we can do. So for this case, there was, while looking at this case, looked at the literature, we found that maybe the cryoglobulinemia has recurred. The HCV is resolved, but the cryoglobulin is still there. So what could be done? So they suggested running the PCR on the PBMCs rather than on the plasma for HCV RNA, and PBMCs that were cultured with mitogens also. So we thought we'll isolate PBMCs and send them for the HCV RNA testing, and we may recover it there. So therein, we took help from Dr. Megha, working in the virology department. And incidentally, at this time, HCV RNA was positive both in the PBMCs as well as in the plasma. So can cryoglobulinemia be a cause of false negative HCV RNA was what we discovered. Sir also mentioned it during his discussion that the cryoprecipitate per se is enriched in the HCV particles. So this was one of the earlier papers where this issue was discussed. And the particles, they get concentrated in cryoprecipitate. This is also highlighted by cases which are negative in the plasma, but only the cryoprecipitate, dissolved cryoprecipitate carries the HCV particles. Incidentally, it is not just the HCV RNA which can be false negative. Even the antibodies can be false negative in this scenario. Now, at this time, we had received the bone marrow also from this patient. So along with that, let us look at the peripheral blood. So again, February 26, the peripheral blood shows a lot of lymphocytes, unlike an adult peripheral blood where you would find more neutrophils. So here the lymphocytes, they are larger than small mature lymphocytes. You have one here for reference, the small mature one. The rest of the lymphoid cells, they are relatively larger. Although they don't look blastoid, they look more innocuous, but they have a lot of cytoplasm as well. On the higher power views, you can see some attempts to form polar projections. The bone marrow was fairly cellular, not a very massive increase in the lymphoid infiltrate on the bone marrow aspirate. The bone marrow biopsy, unfortunately, was not the best of the biopsies, but it clearly indicated the pathology with presence of these lymphoid aggregates. So we ran the IHC on that, and the IHC showed CD20 positive aggregates. Markers for mantle cell lymphoma were negative. Flow was also done, and clearly majority of the B cells, they were sitting as clonal. So the B cell population here is gated and it is all expressing kappa. Few normal B cells remain here. So this pattern was very, very suggestive of a splenic marginal zone lymphoma versus a lymphoplasmacytic lymphoma. Considering the entire picture, we favored LPL. Incidentally, looking back at the reports of this patient, the patient's TLC had been high for quite some time in multiple reports over the last year. There was an oscillation in the TLC as well as in the absolute lymphocyte count, and that sort of peaked around the month of February here. So the lymphocytosis was present since earlier. Herein, one more learning point is that we need to look at absolute lymphocyte counts rather than just percentages, because many times the percentages may be normal, but if the absolute counts are higher, then the patients need to be investigated. Soumya ran the clonality assay from the peripheral blood mononuclear cells, and it indeed confirmed the monoclonality that the peripheral blood kappa lambda already demonstrated. So at HIMAT, this was our final diagnosis. And with that, I would like to call Dr. Geetika back for the discussion of the second kidney biopsy.
Thank you, Jasmita. We are blessed to have so much help as we analyze our cases. Do you want to discuss this slide? Yeah.
So I think Sir talked about this, that initially the HCV infiltrates the B cells using the CD81 receptor. So E2 is the HCV protein. Once it gets in, it sort of drives the proliferation. If it stays for a long time, it converts from an antigen dependent to an antigen independent or an autonomous B cell proliferation. Typically, lymphomas are more common with HCV. There are three types that are more often associated. That is marginal zone lymphoma, lymphoplasmacytic lymphoma, as well as DLBCLs. And most DLBCLs actually arise from transformed marginal zone lymphomas. Incidentally, cryoglobulinemia puts a patient at higher risk for developing this. And unlike all the other diseases here, treating the primary infection can actually cause a resolution of even the lymphoma. So without chemotherapy also, there may be remission, especially in the low-grade ones.
Okay. So things had changed. We were looking at potentially an occult HCV infection, patient with undetectable cryo, with now understanding that, well, we have a weird sort of cryoglobulin. We now have an overt HCV infection from potentially a monoclonal B-cell lymphocytosis. We now have an overt lymphoma. With this information and a persistent proteinuria, we now receive the second biopsy. So you can see how, sorry, this is not resistant, as I understand. Yeah, we now have a detectable HCV RNA. We now have demonstrated serum cryos as positive, and we now have an HCV-related B-cell lymphoma with a faint M band. Now, with this information, we get the second biopsy. We again have good tissue, cortex and medulla, 14 glomeruli, one global, one segmental. we have a persistent, of course, proliferative GN, which is still an MPGN pattern. I'm still not seeing any cryoplugs in this biopsy. The chronicity actually was still similar to the previous biopsy at 20 to 25%, but I did feel that it was much more inflamed. And now with the history that we have a B-cell lymphoma, we are now worried about any direct infiltration. So we ran the CD3, CD20, and we're seeing a good mixed population. We took our hematopathologist opinion. This does not look like lymphoma infiltration, and most of the cells are actually macrophages. So the CD163 is highlighting that the interstitium is full of macrophages, the glomeruli are chock-a-block full of macrophages. So this really fits into the cryo-GN story. What happened to the immunofluorescence? Are we now clearly monoclonal? Is it clear now what this patient has? The IF was exactly the same. So we had two heavy chains, which was the IgG, the IgM, full of C1q with evidence of classical pathway activation, and kappa more than lambda, not clearly clonal. We go ahead with the EM, and then we still see all these subepithelial deposits with vague remodeling happening there. We see some mesangial and subendothelial deposits, few, not too much. So what happened? How has anything changed? We're still at an MPGN, which hasn't thankfully progressed further. We still have the same IF and we still have the same EM. But everything changed because we now had the clinical information to be able to refine our diagnosis from a very vague IC-MPGN to this being an HCV-associated type 2 cryo-GN. And we were very clearly able to say, we don't think that this is actually an MGRS. So just to put it out there, cryo-GN is really a clinical context and lab-dependent diagnosis. It refers to a glomerular or vascular pathology in the context of a positive laboratory test, which really puts the onus on the testing laboratory and sample, the way the sample gets to that lab. It becomes so important in coming to this diagnosis. Demonstrating macrophage infiltration is important in and seen in active cryo-GNs. You may not see organization of deposits. We are taught that cryo-GNs should show organization. It's only 50%. So not finding organization doesn't take you away from this diagnosis. Rarely you can even see subepithelial deposits, as was seen in this patient. And the Bruet classification tells us how to classify these cryo-GNs. What we were worried about was the development of this type 1, but that needs to be clearly monoclonal. So you should have only one heavy chain and a light chain. What we were seeing was type 2, which means that we were seeing a monoclonal IgM directed against a polyclonal IgG. This is what we were noting on IF because you have M more than G, you have kappa more than lambda. So we were not really dealing with an MGRS, we were dealing with this type 2, which was induced by HCV. And just to put out there, how we would analyze this case, the detection of the HCV was so important because if you look at the latest RPS IKMG criteria for MGRS, and if you look at cryo type 2 is included under MGRS, but it cannot be associated with HCV. So we needed everything together, demonstration of cryo to exclude a PGN-MID, demonstration of HCV to exclude an MGRS to be able to nail the case. So this was our final diagnosis. This is an HCV-associated type 2 cryo-GN. There is in parallel development of a B-cell lymphoma, as was shown by Jasmita. And we've given the target to hit very clearly, go after the HCV. Thank you. No. No. So it was only glomerular restricted. So MIDD sort of left the differential diagnosis. Yeah. So I would just like to say that I think Dr. Narayan really, like, you were there, right? I don't know how, I'm not sure about combination cryos and PG and MID because criteria requires us to exclude cryo. So I think cryo testing becomes a very, very important thing. So before I open the house, can we just get Dr. Bhaumik's comments on the case and then we'll...
We had a wonderful discussion, first by the clinician, then by the pathologist. As you will realize that how complicated this case was, and I'm really thankful to my colleagues, the pathologist, the Jasmita from hematopathology for bringing out all the nuances and the full diagnosis, because it was really very complicated. I'll also mention here how we clinicians miss that. Actually, he showed in that beautiful slide that how actually the absolute lymphocyte count was persistently high, which we had also not done. I did give in my protocol the percentages, but it was only afterwards that we calculated the absolute lymphocyte counts, which are always around 5,000. So I mean, it's very important that all of us learn from this and we calculate the absolute counts, which is very useful in many scenarios apart from malignancies. So that is one thing we learned. And now, having this full diagnosis which he has given, what we did subsequently was that second kidney biopsy, of course, didn't add much, but it was mainly from the SME that we learned. So we planned the anti-HCV therapy, and on the 6th of March, you see, this is a very fresh case, no? I mean, so patient is just started treatment. We started the anti-HCV treatment on the 6th of March of Velpa 400 and so for 400. The response is still to be seen. I'm not sure about the response. And then we planned chemotherapy. I'm sorry, I forgot to talk to Rishi this morning. He's from hematology and he's the one who helped out. So he's not here. My apologies to him. So he had planned out the therapy for the B cell lymphoma, and we planned to give bendamustine and Ritux. So because Ritux was to be given, we did the total anti-hepatitis B core antibody as well. So I've given that HbSAg was negative, but then when we did this, that was strong positive. So now we've started treatment for hepatitis B as well, which we'll give before starting the chemotherapy. So as of now, we are still stuck at the same place. The ALC last is 6,900, 49% lymphocytes, and it's proliferative glomerulonephritis with nephrotic syndrome still persisting at 10 grams. So steroids have been tapered now to 15. And let's see how it responds, because it is just 2 weeks now that we have given the antiviral therapy. The chemotherapy is still to be started for the B cell lymphoma.
I'd like to invite some of my colleagues for comments who worked up the case. Dr. Ritu, what was any thoughts? How tough is it to pick up the cryo? How many times should we make sure we send the sample? What discussion do we need?
So this was interesting. We are working mainly in the malignant hematology, and what we see is mostly type 1 cryoglobulinemia. And it's easy to pick up because the amount is so much that, it's very even difficult to draw the sample. So even before the clinician, the people who are in the phlebotomist tells us there is a case. We are unable to, put it in the vacutainer. So, but this case was interesting because it is type 2. When it came to us, we actually didn't get any cryoprecipitate because it came at room temperature to us. The sample was collected and nothing happened. And we got the same finding, 0.2 gram per deciliter IgM and a polyclonal increase in IgG. So that polyclonal increase in IgG was something which we were not comfortable with. Because in any monoclonal gammopathy, if we are getting an M band, normally there is a decrease in the normal immunoglobulins, and IgG, that area becomes a little rarefied for us. We always do not check the nephelometric findings, but this is because we get so many cases, not we don't get requests for immunoglobulins for all our cases. But that was what put us on the alert that something is wrong in this case. It's not run of the mill. Something else is happening here. It's not just the B cell lymphoma. When I had a discussion, then I got a call from Jasmita and I reviewed the case, and that was it. So looking at your electrophoresis is important. Knowing what is aberrant in a particular case is important. And interesting was like We also collected the sample at 37 degrees Celsius. But what was interesting in this case, we still did not get any, cryoprecipitate, because we discussed and we thought perhaps because we are not putting everything at 37, the cryoglobulins are somehow getting enmeshed in the RBC and the clot and not coming in the serum, and we're missing that part. But I understood the case well when I got to know that repeatedly sometimes it is coming positive and sometimes it is coming negative. So there is a lot of fluctuation. And when I look at this case, even in the lymphocyte titer and the absolute count without therapy, there is so much of fluctuation. So those physiological fluctuations, I think it's important for us. The learning that I got is that it's important to see the pattern. And I think now we have in our EMR, and we are going to have more functionality in the EMR of the institute, that you can see the sequential results of the patients.
Yeah.
So that is one take-home message.
And it's a world over problem. Serum cryoglobulin testing is a problem all over the world, where when we're strongly suspecting it, we really need to go after that test and have that discussion. I just wanted to make one last point from the pathology point of view. From that first kidney biopsy, for us to at least not label the patient MGRS was very important for us to dig deeper, because I'm just thinking that if we had suggested that strongly and the patient would have gone on heavy plasma cell therapy while actually harboring an occult HCV infection, it could have been quite disastrous. So that was our job, to say, well, there is something off, and stop there and get more information. Dr. Narayan, we'd like to hear your
I have done one thing. I have put the history into the chat GTP. Okay. So chat GTP has also given the same things like the lymphoma that I was talking about. And I feel still I have gone through the lot of literature search. Everything is related to SCV, persistent SCV infection. As I have told you, subversive mechanism of the virus, that is the one thing. It hides, go into the machinery of host cells, and may remain occult for many years. Getting opportunity can come. And this persistent SCV leads to increased monoclonality that I have tried to explain you. Polyclonal, then it can be oligoclonal, then it can be monoclonal selection. And it can produce similar kind of some immunoglobulins from the B cells, and can also produce some B cells lymphoma that I have already spoken to you during this process. So we should wait for not to give too much of the immunosuppression to treat lymphoma, just treat hepatitis C, and you will see it is quite possible everything disappeared with this. So that was my thinking, that probably the SCV is causing everything. Time and again I was going, but 2 times doing this electrophoresis, making little bit physicians confused. So this is all that I have told you. Something is hidden, and trying to search out for this. Cryoglobulins, I was very much sure this would be cryoglobulins, because this classical teaching never goes wrong. So during my MBBS, in MD, low C4 count, objective questions, take cryoglobulins. Only low C4. So that was the teaching. That never go wrong. So that was the perception of the physicians. This is the reason why I have told you, this is the type 2 cryoglobulinemia. Nothing less except with this hepatitis C. So that was all our things. And chat GTP has also told us it is quite possible there might be the marginal cell lymphoma. So that so this is quite possible. And I was also thinking of whether this was something looking like this lymphoma coming up associated with that figure I have shown you in hepatitis C, when the B cells selections comes in, and then they can large B cell lymphoma. So that kind. Yeah, I think DAA I will like to give. See, for the 3 months, I think everything might disappear. Everything might disappear. This is a very clever virus. Subversive mechanism of the virus, we know that we have already studied. That is very strong with these all viruses. Thank you very much for this opportunity. A lot of things I have learned. Thank you.
Thank you so much, everybody. I will now officially close this CPC. Thank you. So, will join us for